So here's the second talk in the GU male series. This one's on late onset hypogonadism, essentially testosterone replacement. We're seeing less ads than we did for a while, but that's still a very hot topic. And many men come in saying, I feel tired, I don't have the energy, I feel less strong, I think I have a low testosterone. Unfortunately, for many of these men, that's not the case, although in some cases it is, and it is something we need to be aware of and know appropriately how to treat. So testosterone is a substance that is produced by men, also by women. In women, it's actually usually responsible for their level of sex drive. In men, it's responsible for all sorts of different things. So who has late onset hypogonadism, also known as testosterone deficiency syndrome? Well, men that have low libido, erectile issues, decreased muscle mass and strength, anemia, increased body fat, especially visceral, decreased bone mineral density and osteoporosis, decreased vitality, impaired cognition, and depressed mood may have late onset hypogonad system. So unfortunately, as you can see, each and every one of these also has other possible causes, and that's the difficulty, is parsing out which ones are caused by low testosterone versus which ones are caused by something else. So if you have one or more of those symptoms, you check the serum testosterone and you see that it's low, this person may have late onset hypogonadism. And so they do suggest that anyone with osteopenia be checked for testosterone levels. That makes perfect sense. We don't, unfortunately, know very many men that have osteopenia just because there's no real recommendations for doing bone densities in men. If you have someone who has had a lot of steroids, who's had a lot of other risk factors, you may do it. Or if you do an x-ray and you see some evidence of thinning of the bones, unfortunately the bones have to be thinned by 70 or 80% before you're going to see it on x-ray. So that may be an exaggeration, but by a substantial amount. It is something that we need to keep in mind. Some people feel that only a small percentage of low T patients are being treated. However, I will tell you that I have had a number of people that I've treated who really haven't seemed to benefit from it. So who else gets low testosterone? People with diabetes, COPD, inflammatory arthritis, renal disease, HIV, obesity. Of course, you do need someone to have both a low total testosterone and a low free testosterone to have evidence of true late onset hypogonadism. Metabolic syndrome, which is, high cholesterol and hypertension and high weight, and hemochromatosis, which is not particularly common, but I do think is more common than most people think it is. If you have somebody that has a high hemoglobin, it is probably worth doing a serum ferritin, and some of those people do have ferritins up in the 900 to 1,000 range, consistent with hemochromatosis. So who should we test and how should we test them? So if you have someone that you suspect has low testosterone, you should have a sample in the morning. Doesn't need to be fasting, but it should be a morning specimen because it does seem to vary depending on the day, and the tests have been standardized to morning specimens. You basically just do a regular serum total testosterone. The problem is that even though most labs use the same machine, they don't all agree on what the normal is as far as the low end. And so usually the normal is somewhere below 300. And there is general agreement that if somebody's above 350, they don't need replacement. And if they're below 230, they do. The problem is those people that are between 230 and 350. And some folks will replace them. There is some evidence that the benefit of that replacement is questionable, although some patients do seem to have positive effects. So again, there's a very wide range of normal. Lazaro and colleagues in 2006 surveyed 25 different labs, and all of them were using the same test kit, but some had a low range of 130 and some had a low range of 450. So most of them used 2 standard deviations as the abnormal. And the problem is then if you have something that has a greater prevalence than 2.5%, you're going to miss those people. So it's a challenge to figure out who is in fact testosterone deficient. Now, if you have someone that's testosterone deficient, sometimes it's useful to check the free testosterone. The free testosterone is less affected by obesity and by opioids and by some of the other things that can cause an artifactually low total testosterone. If you have someone who has a normal total testosterone, you sometimes want to check the free just to see whether or not there is evidence of low testosterone. If you've got somebody that's below 150, they may very well have a pituitary issue. You can check luteinizing hormone and prolactin. Alternatively, you can just refer them to endocrine if they have a profoundly low. I had a patient that had a testosterone level of 9. Interestingly, he was in his late 20s, came in with symptoms of urinary issues. He was urinating frequently, but we did check it just based on his other history and his concerns about erectile dysfunction. And when we did replace his testosterone, his urinary symptoms did get better. So let's say you have somebody, their total testosterone is below 200, so there's no controversy at all. You've decided to treat them. You need to make them aware that it may take 3 to 6 months before they do see a change in their libido and sexual functioning, and maybe longer for some of the other elements. Basically we don't even decide whether or not anything's got any benefit until we've given at least 3 months treatment. We may have a placebo effect sooner than that. Some folks may be more sensitive, so they may get an effect sooner than that. You may get a synergistic effect with the PDE5 drugs as far as erectile issues. Even though they may still have erectile issues, they may have need for lower dosing on their Viagra or similar. It may improve their body mass, decrease their body fat, and improve their cardiovascular function. The challenge, of course, is that many people feel like male hormones are associated with heart attacks, just because men do have more heart attacks, and so there is concern that maybe testosterone could result in worsening cardiovascular function, but the jury is still out on that one. So how else could you test them? Salivary testosterone is used, but in general it's really not commonly used because there's no real agreement that it's standardized enough. We would test for other endocrine issues only if we really felt there was evidence of thyroid or other similar issues. You must do a PSA and a digital rectal exam prior to initiating the testosterone treatment. Again, if you've got other risk factors, you also need to do a blood count since the treatment can cause polycythemia. In general, you also want to do a testicular exam just to make sure they don't have profoundly small testicles. If you have someone who's older and has had children, that's probably less of an issue. And obviously, if there's any suspicion of breast cancer, lumps, etc., you need to rule that out before you would do testosterone treatment. So let's say you start your patient on testosterone treatment, you repeat the PSA, maybe the DRE at 3 to 6 months, and then again at a year, and then annually thereafter. Also do a blood count at the same time to make sure that they haven't developed a high hematocrit, i.e. a erythrocytosis. If you've got people with high lower urinary tract symptom score of greater than 21, That's a relative but not necessarily absolute contraindication to testosterone treatment, but it may actually worsen their symptoms. So if you've got someone that comes in with a crit high, you need to work that up and figure out what's going on. Of course, that may be a factor if you have someone with hemochromatosis, but almost everybody with hemochromatosis is getting regular phlebotomies so that their hematocrit will be lower. If you have somebody with untreated CHF or sleep apnea, obviously you want to get them on treatment before you do something like testosterone supplementation. So what's your goal? You can base it on relief of symptoms. So if they come in and they say, oh, my energy is so much better and my sexual drive is so much better, you probably don't need to necessarily worry about exactly what their total testosterone level is. If you're basing it on the lab, most people shoot to get it in the lower to mid young adult male range. And so the range is 300 to 900. I shoot for 600. And I'm happy anywhere between 400 and 600. Most people, if you have them in that range, they should start to see some improvement in their symptoms if they're going to. What else can you do if someone really doesn't want to do testosterone? It's not available orally. The topicals are kind of messy and gooey. Sometimes you have to do an injection. So if someone doesn't want to use testosterone, what else can you use? Well, there's not really enough evidence for any other supplements. Some people do use things like DHEA or some of the other things you can get at GNC. Technically, they're not recommended, but I will tell you that I have a number of patients who have sought them out independently and have come back and told me that they were very effective. And in fact, I checked testosterone levels on a few of them, and they did seem to get better. Evidence is not particularly strong. It's controversial to recommend them, but as I say, some folks do seem to get better. There's also some natural testosterones which really have no testosterone in them. It's something that's marketed. Again, you may get some placebo effect, but let the buyer beware. HCG supplementation can be used, especially if there's fertility issues. But otherwise, there's not really a whole lot of benefit with that. There's some of the aromatase inhibitors that also are used, especially by bodybuilders and similar. Those block the conversion of testosterone into estrogen. They seem to increase body mass that way. The aromatase inhibitors, are not approved for supplementation, but as noted, some people use them off-label. We'll see what happens with those. References, I'll admit these references are on the old side. In fact, though, we really haven't heard much from the folks that are making the testosterone or marketing the testosterone recently, and I haven't seen a whole lot of recent research and evidence. The benefits are very real in some patients, but unfortunately, I would guess about 30 people that come in to see you telling you they think they have low testosterone, probably one or two actually do. And maybe one of those people really does get benefit from supplementation. For that person, it can be life-changing, but unfortunately, it has not really turned out to be the panacea that many people had hoped it was going to be. So this concludes this talk, and please post any questions on YouTube or we'll talk about them in class.